to share this first session on barrier and current limits in PROMS collection and use. I am a clinician that set up an MS clinic 25 years ago on the Canadian model, following 6,000 MS patients with a main field of research, epidemiology, clinical trial, and imaging. It's my pleasure to introduce the first speaker, Robert McBurney. Robert McBurney is the Chief Research Officer of the Accelerated Cure Project for Multiple Sclerosis, a non-profit organization accelerating multiple sclerosis research to improve the healthcare and quality of life of people affected by MS. During the last 40 years, he has managed research groups for drug discovery, personalized medicine, and clinical decision support systems at medical schools, research institutes, biopharmaceutical companies, and non-profit organizations in Austria, in UK, and USA. It's really my pleasure to ask Robert to give this talk on the collection on use of PROMS in MS clinical core, preliminary results from the World Group 2 literature review. Robert was the exciting leader of our group. I'm very pleased that he gives this talk now today.
Thank you very much, Gilles. And I'd very much like to thank the organizers of this plenary session for giving me the opportunity to, on behalf of the members of Work Group 2, who come from 9 countries and a variety of academic, clinical, non-profit, and for-profit organizations, to make this presentation of our work group activities. All the work group members have personal or professional interests in achieving improved outcomes for MS. This is a redoing of the slide that Paula showed earlier, and it's essentially a picture of people with MS, indicating that some of the symptoms, disabilities, and quality of life issues can be gained by clinical assessment, but there are the hidden symptoms and quality of life issues that must come directly from the person with MS. We refer to them as patient-reported outcomes, but they can be actively contributed or passively contributed, as we've heard earlier today in the MSDA session. So what is the common way that clinicians find out about the symptoms, disabilities, and quality of life issues that matter to patients? It's usually something like, how have you been since the last time I saw you? But there are challenges to that approach. Insufficient time often is devoted during a clinic visit to gaining the information about the patient's entire experience about their MS. And this came up today earlier because I think that the challenge or the opportunity to collect this information before and frequently before a clinic visit is one of the areas that the PROMS initiative and the work of the clinical management work group can contribute to. Of course, mostly the information is not captured in a standardized fashion and doesn't get into the electronic medical records in that way. And it's rarely used in a formal way in shared treatment decisions. And of course, it's important to use standardized data for monitoring treatment outcomes, particularly when the treatments focus on the symptoms and quality of life issues that matter to people with MS. So what the PROMS initiative is about, in many ways, is a full solution for MS clinical care that enables the hidden symptoms, disabilities, and quality of life issues to be adequately addressed. And that full solution must involve people affected by MS, clinicians, data collection methods, healthcare systems, regulators and healthcare technology assessors, policymakers, and funders and payers. So it's quite a challenge, and that's why the initiative has 4 work groups, and the clinical management work group is just one of those 4 work groups that is working together with the other to achieve our objectives overall. So the agenda, with that background, the agenda for today is to talk about our work group goal, what we've been doing since 2019, particularly the systematic literature review of PROs in MS care that was conducted in the last few months. I'll also talk briefly about some of the initial comments of feedback from Workgroup 2 members on the literature review, and then talk about our plans for 2023. So this is the Workgroup 2 goal, is to recommend existing PRO measures that capture a core data set for use in MS clinical management. Now, why is this an important objective? Well, a paper by Kurana et al. In 2017 illustrated that there were 405 different PRO instruments that have been used in MS research. 323 of those were non-MS specific and 82 were MS specific. Which one is the one to choose? So we have to go through a process in Workgroup 2 to determine which PRO instruments are fit for purpose. And we recognize that a substantial challenge beyond just fitness for purpose is that there are cultural, logistic, and financial barriers to overcome to make PROs routine in MS care. So what have we been doing the last few years? We spent some time identifying multiple goals for using PROs in MS care, some of which are more the province of the healthcare systems work group and policy makers, but for our areas of focus, we've have settled on 2 areas. One is identifying symptoms experienced by a patient, and the second is monitoring disease progression and treatment outcomes. These might require different PRO instruments, but it's important that we have those two areas of focus. We made a decision to commission and put efforts into enabling a literature review of the collection and use of PROs in MS clinical care. We selected Northwestern University, their Department of Medical and Social Sciences, to undertake the literature review in a competitive process. We formed a Workgroup 2 subcommittee that consisted of Helga, Angela White, Gary Cutter, Gilles, and myself to interact more frequently with the Northwestern University folks during that project. And delivered on October the 15th, in time, was the formal report on that literature review. So it's just been a month since we had the literature review. There's been a major MS meeting in between, so we've only had one opportunity for the whole work group to discuss the literature review. But there are some interesting aspects of the literature review. So 573 articles were identified, 5,073, sorry, articles were identified, both from the peer-reviewed literature and what we referred to as the grey literature, which includes conference abstracts and other material on the subject. The process of systematically evaluating those 5,073 articles led to 37 being included as the universe of the literature on the collection and use of PROs in a clinical care setting. So our conclusions were as follows, or the conclusions of the literature review were as follows. The literature, peer-reviewed or otherwise, from the collection and use of PROs in MS clinical care is sparse. And this actually goes along with the fact that there are very few data sets available in a big data sense for use in some of the artificial intelligence efforts that we have heard about earlier today. Another interesting thing is there are about 10, I think, journals where these articles have been published in addition to conference proceedings. 21 of the 37 items were conference abstracts in the 10-year retrospective review period. The articles were predominantly from MS clinics. There's very little reports of the use of PROs in clinical care in a general neurology setting, for example. Interestingly, 29% of the PROs, or the PRO measures used in those articles were MS-specific. That actually matches the 25% in the Curana paper out of the 400. So clearly there are other outcome measures that are being used, and some of them are very common PRO instruments. There are only 3 MS PRO measures that cover broad symptoms relevant to MS, and only 2 articles and 3 abstracts on PROs used to evaluate treatment and care. So, up to the top. The available literature is very sparse on the topic. So, here are some insights from the single work group 2 meeting. And this is not a complete set of insights. We got what we asked for, and whether that was what we expected or not, there's some discussion. The first impression is that we have a blank sheet for 2023 activities towards the work group's goals. One question was, what can we learn from the 442 excluded articles? That's a very interesting question and will take some time to resolve. But there was a comment about the potential that PROs are being collected in MS care settings but not reported because they're not being used in research. So we need to do something to find out more about that. So what's next? The first thing is to present the preliminary results at this PROMS plenary session and our work group 2 plans for 2023. We need to spend more time incorporating the findings from the literature review in our work group plans, and particularly we need to gain more input from people affected by MS and clinicians on their experience of the collection and use of PROs in MS care. And we also need to make, for our selection, decisions on the purposes and contexts for the use of PROs in MS care. So purposes might be to identify symptoms and to monitor progression and treatment, but context may be remote data collection, etc. And I won't go into any more of that. We need to develop criteria for evaluating PRO measures that are fit for purpose. And I just give a few examples here. We need to know what the key symptoms, disabilities, and quality of life areas are covered in the PROs we evaluate. We need to understand how representatively they were developed. What was the input of people affected by MS in the development? Patient burden of the PRO measures is very important. What other data or results do we need to make a full evaluation of the PRO measures? And that would include psychometric and validation of each PROM if available. Delivery methods is very important, patient and clinician acceptability, and relationship to regulatory efforts on PRO measures for clinical trials. And we'll hear a little bit more about that later. And of course, all of these criteria should be developed in collaboration with the other work groups and the engagement coordination team. And then we need to identify, using those criteria, existing PROMS that we could evaluate for the purposes and context. We need to make some preliminary selections and then discuss those selections with the other work groups, the ECT and the Scientific Steering Committee. And then we'll be able to make consensus recommendations of PROMS for purposes and context. And most importantly, we need to publish, but more than just publish. We need to actively disseminate this information if our work is going to make an impact on what happens in clinical care. Thank you very much.
Thank you, Robert. I call the second speaker, Paul Kamudoni. Paul serves as Scientific Director for Patient-Centered Research at Merck Healthcare Group. He has been at the forefront of efforts to build capacity and transform organizational culture towards more patient-focused within Merck Healthcare Group. And Paul is working on the qualification of PRO measures as drug development tools in MS with the FDA. Paul?
So, a very good afternoon to you all. It's a privilege to be here and share some thoughts and reflections on standardization of patient-reported outcome measurement, but really focusing on the connection between clinical care and clinical research, drug development. So I want to start off by highlighting the shift that we're seeing in the drug development setting, driven primarily by the focus of regulatory agencies asking for structured input to be incorporated in drug development. And what we're seeing is companies, of course, are responding by developing very sophisticated models for engaging with patients right from the beginning of the drug development journey all the way through to submission. The other interesting thing we're seeing is there's a shift in not just focusing on obtaining market authorization, but thinking through what would this drug mean for the patient and how would this drug fit in the existing treatment options in the clinical care. So really a more holistic thinking that is happening early on in drug development. Now, all of that is happening in a broader context where we have patient centricity or patient focus being a key element in delivery of care in different disease areas, including MS. Now, if you move forward with that, we are also seeing a shift or an evolution towards more what I would call learning health systems. I think those of you that are involved in systems know exactly what that means. I won't elaborate on that. But the key feature of this is the attempt to create a network of care centers, practices, sharing data that is underpinned by a standardized set of outcome measures, clinical outcomes that are collected across the board. And this data being intended to support both patient care as well as driving research. And if you look at that, fundamentally what that requires is thinking through what you're measuring from both angles. So really you need to think more holistically once you get into that, that setting. And just to mention a few examples, we have MS Parts, I think most of you know that, where they're collecting NeuroCore and other assessments. We have MS Link, which is collecting PROMIS fatigue and PROMIS physical function measures in addition to other assessments. Now, what we really need, I think, is something that's been already mentioned in the previous, by the previous presenters, is a way for us to connect to have a universe of what we're measuring, so call them core outcome sets, call them domains, and then we're able to link from that universe things that we want to target if we're developing drugs, and that could be very different. I'm just speaking several examples based on the efforts to qualify measures by the CPAS, which is focusing on fatigue and physical function, but it could be other symptoms. Whereas on the clinical care side, there might be a broad range of outcomes that are interesting, and also, as Robert mentioned, there might be different goals for assessing. So you might have different tools that you need for different goals. But all of that needs to happen within a broader framework, a single universe, which is concept-driven and concept-supported. So what we really need is a way of making it all fit together. Now, if you look at one particular concept, there are ways out there based on psychometrics and advances in item banking and other technological advances that allow us, for whatever concept we decide to measure, whether it's fatigue or physical function, to be able to use the same assessment ruler or assessment metric, but apply different instruments. So for example, in a trial, we might include a longer instrument, what you see on the left-hand side, the PROMS Fatigue 8A, but in a clinical context, we might use a computer adaptive test, which only allows you to assess certain minimal number of items or questions, but still be able to score both of those things on a single common metric. Now, if you combine this to what I just showed in the previous slide, then you're beginning to create a universe which allows you to holistically look at things, but be flexible in how you're measuring things depending on what you need in a different context. Now, on a more practical level, I was asking myself, how can the efforts that we're doing to get the measures, patient outcome measures qualified within the context of a working group at CPAT with the FDA, how can that benefit from activities and insights that are generated from clinical care and clinical practice? And I think there are a couple of ideas or suggestions I'm just throwing out there. One of them is our understanding of what patient outcomes really inform decisions in the clinical practice. That's something that we can only learn by looking at how decisions are being made in clinical care. And then if you look at a particular aspect of information, so fatigue, what does that tell us about the disease and how the disease is evolving over time? And then also thinking through what are the needs of clinicians for them to be able to effectively interpret and apply patient-reported outcome measurements in their context. So all of this information is information that could and should be gathered, generated in a clinical care context, and that information will directly support or underpin activities to justify why we're looking at certain things in a clinical research setting. Now, just to finish up, just some thoughts on, okay, where do we go from here? I want to highlight that actually we start and we end with the patient, because if we can zero in on that, it means whether you're in a clinical care context or whether you're in clinical research context, you're really zeroing in on what matters most. It's just that you might focus on different elements of that. And then second, once we figured out what is important in that sense, then we might need to think through the core outcome sets or universe of domains that we want to target, and also think about how we want to apply systematic or sophisticated measurement approaches that give us flexibility. But ultimately, I think to move us forward in a way that bridges what's going on in clinical research and clinical practice, what we need is these sort of settings where we are collaborating, so we bring people from clinical practice as well as people involved in drug development and clinical research. Thank you.
Thank you, Paul. I call for the next speaker, Usman Khan. Usman is health policy and management professional with more than 25 years experience. He is currently a senior advisor at the Good Governance Institute, a UK-based consultancy, and at FIFPRA International, a Brussels-based European public affairs consultancy. He is a regular public speaker and writer on health policy matters and authors, most recently, of Health Management 2.0.
Good afternoon, everyone. I'm very sorry not to be there this afternoon in Livorno with you all, but I'm very happy to be making this short presentation on behalf of Working Group 4. Other colleagues are in the room with you who will be able to take this discussion forward. But my job really is just to update you on where we've got up to and some of the issues that we'd like to be able to discuss today. I thought to sort of start by sort of taking one step back in terms of giving colleagues a sense of where we are as a working group. And I think whilst these vision and mission is not something that we've sort of officially put into the working group, I think it does give a sense of where we're looking to run to. And that idea of what are we trying to do in Working Group 4, well, I think as a vision, we'd like the embedding of the lived experience of people living with multiple sclerosis. We hope that it facilitates improved treatment and care. And that link, that idea of being able to have that sense of what good looks like. And so connecting that to a mission, it will be to ensure that PROs form an integral part of all aspects of health policy and practice. And I hope by that you can then see how that aligns to the other working group themes. It should be said that originally when we set up the working group, the original focus was to actually go out there and advocate for the use of PROs in multiple sclerosis policy and practice. It was as simple as that. And we felt that we could go out there, talk to policymakers, talk to politicians, talk to others working in that health policy community to be able to advocate, make the case for their use. But we soon realised that we were probably being premature in our ambition to do that. And therefore we revised it to an assessment of the case for change. So we wanted to be able to test it before we went out there and took it there. The work that we've been undertaking has been led by a number of colleagues, but centrally by MSIF, and with the support of regional and national MS societies, obviously with the support of the working group members who have been absolutely fantastic in this. And I'll also say we've had good support from universities, including KU Leuven. What we've done is we've been undertaking case studies in Italy, the UK, USA, Canada and Argentina, and we're also cognizant that we need to be aware of how less developed countries may be working in this space. So that's something that we want to be able to work with. We know that, and as I say, so this is rehearsing what you'll all know, because this is really what the PROMS project is about, all the areas in which PROs can work in clinical research, medicines development, clinical care regulation. But of course, our central focus is much more around that resource allocation, where those decisions and thoughts and reflections on ML's health policy and practice are first made. And you can see there that while they may be evolving in clinical research and growing in medicines development, it really is very exceptional to see PROs in any way in health policy and practice. But we also are very aware that PROs face many barriers, and these barriers obviously will overlap across the different working groups. But for us in working group 4, we know issues of practicality, of reliability, the subjectivity of PROs, trying to get any sense of standardization, as well as, of course, the impact of people living with MS, of undertaking and completing PROs. So we know that before we ever get to the policy level, there are a whole host of issues that need to be addressed before we're going to get that receptivity developing. But what we do know, and I just put this slide up just to be able to say that we can see, and it's fantastic to be able to see PROs do form. This is just from an article being able to look at how clinical trials work and the look at trial endpoints, and we can see clinical outcomes, biological markers, other composite measures, but PROs now are centrally there, so we can see that they're there, and it's how do we get those to feed up into that policy setting. So what we wanted to do was to assess in what form PROs could inform health policy and practice, and we felt that this could be in a whole range of ways. What does good look like if we get there, if you like? So it could be through patient surveys, it could be through research studies, it could be through aggregate clinical reporting. And what we want to be able to do, and what we're doing, is to be able to do a secondary review or a small series of national case studies to see, is there evidence of any of these forms of dissemination PROs into health policy and practice actually happening? So that's part of that baseline work that we are undertaking. In terms of being able to locate PROs in health policy and practice, we've already talked about resource allocation. When making decisions about how much funding to put into MS care, the ability to be able to reflect on PROs at that policy level will be important. We've already seen it in regulation, and we know that in regulation PROs are used as a metric. On commissioning services, and this again is what we feel in terms of our ambition, and when we're saying embedding PROs in health policy and practice, we would want to be able to see commissioning reflecting on evidence coming from PROs on, let's just pick one area, just fatigue as just one factor. How do we make sure that an issue in terms of measuring fatigue of people living with MS is included in commissioning frameworks? And then again, in terms of the needs assessment, what do we need in terms of services? So PROs should be there in all those levels. And again, what we're looking to do is conducting a small secondary review, national studies, to be able to see where the current state of play is. In terms of the stakeholder groups we're talking to, we should be reaching out. And remember, we've said that we're really, at the moment, feeding through our national MS organisations as well as MSIF. But we want to be able to connect with ministries of health, health policy units, academic institutions, regulatory bodies, and out into industry. And that's part of the ambition of Working Group 4. And the domains of investigation, we want to be able to see, as I say, multiple sclerosis policy and practice landscape, assess forms of evidence, see the use of PROs. As I say, we're seeing that as being very exceptional when, where and how. Levers to increase stakeholder commitment to PROs. So what would it take to be able to get that increase in interest? And pathways for the inclusion in policy-making process. So what we need to be able to do in terms of the domains of reporting, what you should be seeing as an output from our working group, and this is the work stream 4.5, baseline, those points of receptivity, so stakeholder pivot points, what is likely to be able to get that momentum behind this, drivers and resistors for change, and then the recommendations. This slide, colleagues may want to go back to after the presentation is finished and during Q&As, but you can see how it's working, moving from the scoping and governance, methods to development, method application, and how we're working. I think we're working very strongly as a group with colleagues who have been very, very loyal and very, very supportive over time. So next steps then, we need to finish the field work, and I think Anne is in the room and we'll be able to talk more about that, write that up. Then I think the central part is what form of report do we produce for this working group. The idea of having an event, I think, and we talked about that specifically around this issue, could be something very interesting to be able to talk around. And then is there a next stage of the work progress? As we say, this is being able to do a proof of concept. If we've been able to prove the concept, where do we take issues next? So again, very sorry not going to be part of the Q&A or the discussion. As I say, I've been held at another meeting in the UK, so not able to attend, but all the very best of luck with it, and I'm very much looking forward to hearing the output of your discussions.
Thank you, Usman. It's time now for some discussion. And there are on the screen at least two questions. I think, Robert, for the first one, how were PRO defined for this review?
I can't see the screen. What is the question? So we developed one of the pieces of work for enabling this literature review was fairly extensive work on the keywords and framework and concepts for the literature review to go and look at patient-reported outcomes. And I think that the definition of patient-reported outcome for this review was primarily the active contribution, not passively contributed PROs.
The second question is, which is the current weight of existing PROMS in supporting a clinical decision, and which are the plans of the initiative to improve those weight? I think that we can conclude that with the review of the literature that we don't know really the weight of existing PROMS in supporting a clinical decision, as the experience to use PROMS at an individual level is very sparse and not clearly well evaluated. Most of the time, when PRO is studied, it is in research in field is to have evaluation of the importance of the different domains that is in the PRO measurement, or to compare some traditional evaluation to some PRO. As an example, Benedict compare the weight of PRO compared to the neuropsychological test and show that it was successful to use PRO. But to use it as an individual level, there is no clear experience that have been published at the individual level for clinical care. So that is really the challenge. And when we discuss with Robert this result of this review of the literature, came the idea that rather to speak about patient-reported outcome, we should speak also about patient-supported outcome in the way that to introduce in the clinical care pro probably some more active behavior of the patient with MS might be important to change the culture of the neurologist in order to accept the intrusion of PRO in the clinical care. And Robert, I have a question for you about if we introduce at the individual level the use of PRO, probably there is a need of a special educational program for the patient and also for the physician in order to well interpret and well use PRO in the clinical care. What's your comments about that?
Yes, I think, is it on? I think that actually that falls into the category that I mentioned, which is overcoming the cultural and logistic barriers to the use of PROs in the care setting. And I think that we need to think of continuing medical education related to the use of PROs in care, and also continuing patient education on the use of PROs in care. And one of the things that I learned today from the MSDA meeting was that in terms of digital competence, patients outweigh clinicians 10 to 1. And so if you think of, for example, the United States, we have a million people with the MS, and I don't know exactly the number of neurologists that treat people with MS, but I'm sure it's fewer than 10,000, given the number of neurologists in the United States. And so I think that considering people with MS and people affected by MS, their care partners, etc., as the army of people to translate PROs into effective use in care settings is a very important concept.
Things. So in the UK, we already do a lot of this. We collect PROs on a long-term basis for 12 years now. Our participants have been involved from the outset in assessing what those PROs are and their familiarity with them, and they can take them to the neurologists to see what's going on. So it's more just an observation about for those registries that do make use of PROs and embed them in clinical care, and the participants are used to collecting them in a sort of an ongoing way. It's not just us, it's Sweden, it's Germany and others as well. So I think the perspective of existing registries is really important to ensure that it's within that sort of environment, that it's not just a purely academic exercise. The collection of these PROMs has been going on for a number of years, and it should be reflected in sort of the program. That was all.
Yeah, I think that's a very good point, Rod. In fact, as we talked about how to gain that unreported information, I think that the MS Data Alliance catalog, which does include situations where PROs are collected but may not be reported in their context in clinical care. And so that's why they didn't come up in at least the precisely reviewed articles. So the question of what's in that 442 that were excluded, I think is a very interesting question. It'll take a little time to get that information, but also I think the MS Data Alliance catalog is an important aspect to looking at what's collected and possibly used in clinical care.
We have Cindy Nowinski with us on the screen, and I would like her to comment about the difficulty to pick up real experience in clinical care of the use of PRO, although you did a huge work in the literature, but at the end, no many reports allowing us to understand the weight of PRO in clinical care.
Hello. Hopefully you can see and hear me okay. It looks like my internet is having some issues. Thank you for allowing me to be part of this Q&A. As I understand, so the difficulty in finding actual use in clinical practice and individual practice is, I think, due to a couple of things. One being that, as Robert noted in his slides, there's things going on that aren't necessarily reported in the peer-reviewed literature, and finding those will take a different approach than looking at the literature. I think also perhaps expanding the definition of use in clinical care can be helpful in understanding what would work at the individual level. So in an individual patient's clinical care. In the literature review, we did include some examples of larger learning health systems and so on, but there were things that were at a more macro level that were not being used for the individual patient, and therefore we did not include in the lit review.
Thank you. Patrick?
Maybe a question for Paul, and probably the last question because of time. So I appreciate really the works you have done with PROMS MS, and especially for fatigue, because fatigue is a critical point for the patients. But why you will consider that this specific scale is better than the others? Because to the best of my knowledge, there is only few or even no comparative studies across the different PRO, and especially for fatigue. I think it's a key point for us today, because shortly we need to make some choices at the end.
Yeah, that's it. I hope you can hear me. That's a really valid point, because we need to be making instrument selection decisions based on core evidence. And there are two elements to look at. One is you could look at the comprehensiveness of an instrument to assess the particular domain of interest. And for the new measure, the PROMS Fatigue Gate A, that has been really built from bottom up to focus on issues that are relevant in MS patients. So it ticks that box, but there might be other instruments ticking that box too. The second piece is evidence around how the measurement is actually performing. So ability to detect change over time, ability to discriminate between people that have worse fatigue than those that have low fatigue, ability to work well in mild fatigue or in much more severe fatigue. I would say we've looked at some of those elements, and what we've seen is the 8A performs better than the fatigue severity scale. We actually put out an article on that, and we also compared the 8A against the MFIS subcomponents, and for that too, it performed comparably. So not necessarily better, but actually in a way that is similar with just 8 items. So those are my initial thoughts on some ideas on selecting or helping selecting the right instrument.
The last short question or comment.
Yes, so thank you. It's really fascinating that we will have the review, and that apparently there are not many instruments really being used or valuable, but the promise is very attractive already for a long time. How do you explain that it's not being taken up actually in research and practice that much?
I actually think it's being taken up. It's just that it's taken a while to get to that point. And part of that is people are used to using the same instruments all the time. Nobody looks at the actual data and saying, for our population, what makes sense, what's working well. And I think that tipping point is already there. We should be getting to that. But part of that is getting all the data that people have on these measures out to show that the measures work well in different populations.
It is publicly available? I mean, are there barriers in using it, or can it be enhanced or changed?
You mean the PROMS as a system? I think there's always room for improvement, right? So we shouldn't be too arrogant and say there's no room for doing that. But I would say that what's out there, if people took a look and understood the worth of work that's behind the item banks and the existing short forms, I think people would shift towards those measures, yeah.
I'd just make a comment on that, just one comment. In as much as if you're interested in fatigue, you're not just interested in fatigue. The PROMS suite contains similarly developed, similarly metric in sleep, depression, etc. And so it makes much easier when you're looking at sort of the whole experience to compare. For clinical development, you could argue that a different instrument was useful, but I think in the clinical care setting, having things that are derived from the one source makes a lot of sense.